Okay, go. Hello and welcome everyone to the Oregon Office of Rural Health MBQIP Educational Webinar Series. Today's presentation is titled MBQIP Program Overview. My name is Carrie Beck and I will be your facilitator for the event today. This event will be recorded, and we have started that recording now. This recording, the slides, and other materials used during the webinar will be available on the HealthInsight website, and we will notify you when these materials are available. We would like for everyone to be able to participate in the Q&A session and follow along with the slides. If you joined the Zoom meeting using a web link and do not have a microphone available to use through your computer, please remember to also call in using the phone. You'll find the web link and phone numbers to call into directly in the Outlook appointment. Please chat us if you have any questions about that. Again, my name is Carrie Beck and I am a project coordinator with HealthInsight Oregon. I have two of my coworkers sitting next to me right now. To the right of me, I have David Smith. David Smith is also with HealthInsight Oregon and is our HIT program manager. And to my left, I have Katie Urau, and Katie is a project assistant. HealthInsight has partnered with the Oregon Office of Rural Health to provide education, technical assistance, and opportunities for peer-to-peer sharing for critical access hospitals participating in the MBQIP project. We have scheduled a series of webinars and roundtable calls through July, and we will also be hosting a workshop at the Rural Health Conference in October. You should have received Outlook appointments for all of these events. And if you didn't, just let me know and I can add you to the contact list. Also feel free to forward those appointments to your colleagues. Next, I'd like to call your attention to the chat feature. Feel free to use this feature throughout the webinar to share your thoughts and post questions to your peers. There will be time at the end of the session for questions, and feel free to chat in your questions throughout and we'll make sure we'll do our best to get to them during the Q&A session. Our presenter for today is the lovely Ellen DePrat, and I will turn it over to Ellen now to introduce herself and start the program. Thank you, Ellen.
Looks like, Ellen, you may need to unmute yourself. We're trying to unmute you from this side, but it looks like you might have control over it.
Okay, there.
There you go.
Oh, thank you. Hi, can everybody hear me? This is Ellen. And I want to introduce myself and actually say thank you for everybody for joining this presentation. Okay, I'm not sure. Oh, there we go. So as you can see, I've put myself down as a registered nurse with over 20 years experience and realized that I have almost over 40 years experience, which is sad to say, making me older than I want to be. But within acute care, managed care, physicians' offices, and quality improvement work. Most recently, my last 17 years have been with HealthInsight as a project coordinator and manager, working closely with hospitals for the most part. So I am pleased to be here, and a lot of you I got to meet during my travels last year in Oregon, so I'm glad to have you all back for this refresher. Our agenda today is just to do an overview of the requirements of the MBQIP program, any prerequisites to your ability to be able to report on that program, the current measures that are in there, reporting tips, and then a quick wrap-up to see if there are any questions from the group. We want to articulate the components of the MBQIP program as it is a little bit different than the CMS's program for the acute care hospitals. Outline the steps for enrollment and data submission, and then understand the current measures and the required reporting databases that are associated with those measures. And then, as always, we want everyone to be successful in fulfilling the Flex Grant 2017 requirements. So starting out, obviously, the impact. There are 1,339 critical access hospitals in the United States. So you are a large group of people. And there are 57 million people living in rural communities. So you're servicing a huge amount of people, and having you there is key to those people having health care. So the Medicare Beneficiary Quality Improvement Project, or MBQIP, we'll be using throughout this presentation, was created in 2010 as a key quality improvement activity within the Medicare Rural Hospital Flexibility Grant Program. And this project for quality actually kicked off in September of 2011. And there's a reference there that you can get more information if you're interested. The goal was obviously to improve the quality of care provided in small rural critical access hospitals. And overarchingly, to establish some national benchmarks that were more relative to what it is that you do versus what the acute care hospitals are capable of doing. And even though the cause have a low patient volume, everybody must realize every patient does matter. So we want them to get the best care in access close to home. So the prerequisites, if you're not already aware of it, most of you have in past completed an agreement with your Flex program. You needed to have registered in the QualityNet Secure portal, or registered with QualityNet and then enrolled in the Secure portal, and also completed your inpatient and outpatient notice of participations. Those are now online, and you do those once you're in the Secure portal. And then you need to contract an authorized and approved measures vendor if you're going to use one, or install the CART software. CART is a free CMS clinical abstraction and reporting tool software, and it's for extensive, its use is for the inpatient and outpatient reporting programs. So step 5 would be to enroll in CDC NHSN, which is the National Health Hospital Safety Network, to report on the healthcare personnel influenza vaccination. And that is the OP27 measure that we will talk about. Contract and authorize via the Secure portal a CMS-approved HCAPS vendor to submit your HCAPS data. You must be an approved CMS HCAPS vendor in order to submit HCAPS data. So that's why you have to then authorize that vendor via the Secure portal on behalf of your hospital in order for them to be able to submit into the warehouse. And then to use the online tool that's available from Stratus Health to record the data on the emergency department transfer communication. And this will allow you to print a summary report that then gets submitted to your Flex coordinator, and they then submit that report on to the Office of Rural Health on your behalf. So the MBQIP program has quality domains. There are 4 of them: patient engagement, care transitions, patient safety, and outpatient. And so we're going to start with the patient engagement quality domain. The patient engagement quality domain consists of the HCAPS measure. So this is the Hospital Consumer Assessment of Healthcare Providers and Systems, or HCAPS for short. Your population is all of your inpatient discharges meeting criteria for survey. And there are certain things such as if they died, or if they left AMA, those kind of things that precludes people from being actually surveyed. So that is information that your HCAPS vendor will give you instructions on how you send your claims information, and then they will do the random selection of and sampling of those that they call for survey. And then once you have given them permission from the transfer portal, then they will upload the survey files on your behalf to the HCAPS data warehouse. So the care transitions is the next quality domain, and the care transitions is the emergency department transfer of communication, or EDTC. This one has 7 subcomponents, and then those components are added up and you get a total score of how well you've done on meeting all 7 of those components. This population is all of your transfers that are from your emergency department. So if you have up to 44 transfers, then you report on all of those. If you have greater than 45 transfers in a month, then they want you to submit a sample of 45 cases. So you can, choose and select those on a monthly basis or on a quarterly basis. Sometimes it's easier to do 15 every month, and sample those and keep track of that. How you go about this is that you basically use an online data collection tool that Stratus Health has set up. Once the data is entered, the tool itself does become PHI. So when you run your report, you want to do that summary report and not pull off reports because they will contain PHI, and we do not want those being transferred to the Flex coordinator. The tool itself looks like this. So your data collection tool screen will take you to that. You will basically just click to start your data collection. You'll tell them what the time frame is, and then you will put your information in there. And at the end of that whole instruction packet, which you can get from anybody in the Oregon office, you will be able to print that summary report and get that to your Flex coordinator. So patient safety domain. And we are going to go through these pretty quickly so that there's time for questions and to allow you that time. Patient safety is the influenza vaccination among healthcare personnel. This is the one measure that was added most recently and does require an enrollment in the NHSN, or the National Healthcare Safety Network, in order to do this data entry. This is a once a year entry. It is done by May 15th of each year. And it does include all of the healthcare personnel that work at least one day in your facility between October 1st and March 31st. So in October, hopefully you all started collecting or have a list of all your employees and anybody who might have been in there, and you've been asking them whether they were vaccinated by you, vaccinated by someone else, they have a contradiction, or they don't have a vaccination. What happens with the data entry is that NHSN will overwrite your data. So the basic recommendation is that you collect this information between October and March on the worksheet that is provided, and then you do data entry only once, so that your data will not be overwritten. So after March 31st, if you've reached out to everybody and you have all your numbers, I do believe that NHSN has said that data entry will open on April 1st and be available for you to complete that survey. And we have a couple of screens that go through a little bit more in detail. This is the screen that you will see once you have the module for the influenza, the healthcare personnel safety component. This will be your home page that you will see when you go into NHSN. You will then have to add your reporting plan, and that reporting plan will last for the entire year. So you select a month and a year from the drop-down. Basically, you can select June of 2017. You can click the box next to Influenza Vaccination Summary and hit Save. And that is the little box that's on the bottom of your screen. And this will last through the entire vaccination season. Influenza and seasonal are the default choices for the vaccination, and so you will not have to change those. The flu season, you will have to actually go in there and pick the flu season, which for us for this year will be 2016, 2017, and then you will also save that. That will then bring you to the screen that actually has the worksheet, and the worksheet gives you the 4 categories of personnel. The employees on your staff are the first, your licensed independent practitioners, which is your nurses and your PAs and your NPs, any students, volunteers, or trainees. And then there's a category for other contract, and that is a voluntary category right now, so you do not have to go to any of your contracted workers that are out there unless you want to. And if you've collected it, then NHSN would be happy to have those numbers, but it is voluntary for that 4th category. And then once you've put in all your numbers should add up. the number who worked in the facility, the top box, all of the numbers after that should all add up to the same number. So that's one good way to check and see. And if you have not and they don't add up, you will get an error message and ask you to go back and make sure that all of your 4 bottom boxes actually add up to the top box. Once you have saved it, you should get a screen that actually confirms that you've saved. So the save of the data was successful. It will tell you that. You can print this form, so you will have it for your records, which is always a good thing to have. And then always, always, always with NHSN, the reminder is that generate a new data set before you exit and before you run any reports. If you do not generate a data set, then your data will not be saved. So if you exit out and log out before you've actually generated that data set, generating a data set, you just go to the analysis, you pick that generate data set icon, and it will start generating that data set, and you can leave. You can log out once the data set process has started, and the next time you go in, you can check whether it actually was successful by looking at the date when the last was generated. So that will tell you. So if your numbers or your information isn't there, always try doing a data set generation, and that should update everything that you've put into NHSN. We'll move on now to those that are in the QualityNet. So the QualityNet portal, qualitynet.org is your home page. Basically what you have on the screen here is the CART software kind of showing you, but these are all divided by hospital inpatient, hospital outpatient. All of this is public knowledge. You can go in there and look at specifications manuals, you can look at memos, you can look at web events that have happened, all from the qualitynet.org, which is a public page and doesn't require any special registration. But what you'll do is, whoops, sorry about that, is you'll actually go into the login for your secure portal. So from this home page, that's how you get to the login and you actually get into the system. So for the measures for the inpatient program, there is only one, and that is the influenza immunization, or the IMM2 measure. You're going to enter this data into the inpatient cart or through your vendor. This is for all inpatient admissions, but this does not include observation patients. So any inpatient 8 months of age or older, your sampling size between 153 and 76 discharges would be 153. If you have anything more, less than 152 discharges, it's 100% of your sample size. And for most critical access hospitals, I would suspect that on a quarterly basis, that is the case, that you'll be doing 100%. We haven't talked about population and sampling. It is a field that's in the secure portal, and then you are asked to fill in the numbers for population and sampling. And in this particular measure, it's going to go into the category that's called global. So when you scroll down, you're going to see AMI, you may see pneumonia, you may see surgical cases. You'll see a number of categories in population and sampling, and what you want to look for is the one that says global, and you will put in the numbers of Medicare and non-Medicare patients, inpatients, and then you will save that. And even though this measure is submitted quarterly, the data is calculated on the 6 months of the flu season. So that would be Q4 and Q1 of each year. But CMS, in order to be consistent, asks that everybody put in all of your inpatients every quarter. What will happen is that once you put the demographics for your patients in there, the CART tool will say that the case is complete for quarters 2 and 3 of the year. And then you just have to send that file off through the secure portal. And yeah, so that's the outpatient. Your outpatient measures are the bulk of the measures in the MBQIP program. So you have outpatient 1, 2, 3, 4, 5, outpatient 21. These are your AMI and chest pain patients for outpatients 1 through 5. So again, this is 100% sampling of your patients. These are the patients that are discharged or transferred to a short-term acute general hospital for inpatient care or to a federal healthcare facility. So you will want to look, the principal codes are always listed in the specifications manual in Appendix A. It will give you the outpatient table. This one happens to be table 1.1. Will give you all of the codes that apply to AMI and chest pain patients. So if you have your claims people or whoever that can identify for you the DRGs that are associated with this or the ICD-9 codes, this is what you would want to do, is try and match those up. If you suspect somebody's AMI and chest pain and you want to go ahead and do the worksheet on them, then once you have the final principal diagnosis code, you can include or exclude those patients. Pain management, which is OP21, is the median time to pain management for long bone fractures. Again, this is a report 100% unless you have, if you have fewer than 80 cases, which most people will have fewer than 80 cases of pain management. Appendix Table 9.0 is quite large, and long bone fracture involves any bone in the body. So any long bones, even those in the fingers. So Table 9.0 might be something you want to look at. It's a massive amount of codes, and we're not quite sure why they made it so extensive. But these are the ones that are eligible to be sampled in your hospital. OP18 and OP20, these are your timing measures. Median time arrival to departure and door diagnostic evaluation. So these are a sampling of any patient who's discharged from your hospital emergency department if they meet one of the E&M codes, and that's on Appendix A, OP Table 1.0. That's your basic emergency medical codes that are on there. So if you have greater than 901 emergency room visits in a quarter, then you're going to sample 96 cases. If you have less than 900 in a quarter, then you're going to sample 63 cases. So again, this is just a matter of picking and choosing when you want to sample and how many you want to do, and just keeping track of those. The structural measure, OP22, is in the outpatient measures, but it's actually an annual submission structure, what they call structural measure. So you will use administrative data and not claims data for this particular measure. So you're going to go in and you're going to basically ask for all of your emergency department discharges and how many of those actually left without being seen. That is a codable entity, so hopefully your claims and your people will be able to look at how many of those actually were coded as left without being seen. This is an aggregate number, and it's a numerator denominator data submission only. It's in the secure portal, and it's due by May 15th annually. So that was very quickly going through all of measures that there are. Basically, the helpful hints for some of these is that you will get from the outpatient support contractor in your secure portal transfer folder. You should get a list of the outpatient claims for all of your patients that are CMS patients, so Medicare fee-for-service patients. So that would give you a start on knowing how many patients you have for AMI, chest pain, pain management. If you happen to want to report on some of the other measures, that will give that to you as well. But the best thing is to make sure that you go into your transfer folder and see if you have your claims report, and that's a good start. So if you, I'm going to confuse you, sorry. So once you know the number of patients you have, and you will be entering into CART or have gone to your vendor and your vendor has confirmed what you need to do to complete the information that they need, then you will go into the population and sampling for both the inpatient and outpatient, and you will put in those numbers. The population and sampling is due by the 1st of every month. The inpatient submission isn't due until the 15th. But the outpatient is also both population and sampling, and your cases are due on the first of each of the reporting quarters. So if you have no cases, remember that entering 0 in the population and sampling is the way that you can ensure that you get credit for doing a report every quarter. So if you had no applicable cases, then be sure you get credit for that by putting zeros in your population and sampling. As we said, for the reporting tips themselves, use the code tables. You know, you can potentially give these code tables to whoever's doing your claims or whoever might be collecting that information. The inpatient measure is reported for all inpatient admissions, so that's 100%. Your chart abstractions, you can use the CART software. Then you create your CART export file. Place that in a folder you can easily retrieve. So once you've created that file, make sure that you can find it, whether it's on your desktop. And then you're going to import that file into the clinical warehouse using the secure file transfer. So you will have to log into both CART to create your report and then into the CMS secure portal to actually import. The process normally from CART is CART will, the minute you've created that file, it will ask you if you want to go ahead and export it and import it into the warehouse, and then it will lead you directly to the CMS login page where you can register and go ahead and complete that submission. If you're not ready, you just say no, and then you can go back and go separately into the CMS secure portal and upload that file at a later time. Once you have done your file transfer, it's real important to go in there and run reports. So from your secure portal, you can hit the run reports, select your feedback reports, and you can run a case status summary report. And that will confirm that whether your cases were accepted or rejected, both the number of cases and how many were. If there were any rejects, then you need to go back and check those, and you will have to resubmit the entire file again. The resubmission will overwrite the previous file, so please don't resend just a complete file. You know, resend the entire file, not just those with errors. You can also run a population and sampling submission summary, and that will confirm the number of cases which were submitted, or that zeros are reflected. If there's none, there's no eligible. So the FLEX program really wants you to get credit for reporting. So this zero population and sampling is very important to your FLEX coordinators. So in somewhat of a summary, the benefits to participating in Medicare Beneficiary QIP. Its inclusion is in your quality improvement projects. It's relevant to the care provided to your patients. These measures were selected as the ones most appropriate. It allows you to be able to benchmark with other rural and critical access settings. It gives you access to technical assistance from both stratas, from your FLEX coordinators, from your QIO, QIN organizations. And it allows you the opportunity to be viewed as the quality improvement leader. And at some point, reporting will become non-optional, and there will be some payment penalties or payment structure placed to this. And for your grant funding and your FLEX program, they do want to continue to support you. And one of the ways that they have to do this is that they have to show that there is compliance in reporting to the MBQIP program. So these are just a few of the resources that are out there for you. The QualityNet Help Desk is always one of your best friends. Sometimes a phone call will get you a support person right away who can solve your problem. An email can always be sent as well. But if you're really struggling or you're locked out, you do every 60 days need to be sure you've logged in, because they will basically throw you out of the system. So, and every 60 days you need to reset your passwords That is both for NHSN and for the secure portal, so very important to just log in and log out. Even if you're doing nothing, put it on your monthly calendar. Just go in and make sure that you do not get yourself locked out of the systems, especially when a deadline is coming up. And I will now turn this back over to Carrie and her group, and we'll see if there are any. This is basically the reporting overview guide, apparently here, but I will let Katie take over from here.
Okay. Thank you, Ellen. On this slide, this is the Oregon Quality Reporting Guide that we have talked about in the past and are highly encouraging the use of. And we appreciate Namrata Davi and the Office of Rural Health creating this document. And next slide. So here are some, just an overview of what we covered today and related to the learning objectives. So we hope that you will give us feedback and let us know if we did meet the goals of the learning objectives for this presentation. Next slide. So I wanted to briefly, excuse me, talk about an exciting new project we have here at HealthInsight. Today is actually the kickoff day for a new project that we have that's devoted to preserving the power of antibiotics, known as our Antibiotic Stewardship Campaign. So we have lots of new materials and new support to be able to give to outpatient settings around this topic. These would include educational materials, technical assistance with your prescription protocols and measurement, professional education, and learning and action network events where you can share with your peers. So more to come on that. This program is based on a CDC program called Core Elements of Antibiotic Stewardship, where the CDC has put a lot of energy and money into developing what interventions actually work in terms of preserving the power of antibiotics. And it is based off of a lot of work that has been done in the past in the hospital setting, which I know, which I'm sure many of you are aware of. So antibiotic stewardship has been moving in the right direction for a while in the hospital setting, and we want to put some emphasis and some energy into moving in the same direction in outpatient settings, which would include clinics, clinician offices that are attached to your to your hospital. It would also include emergency departments, ambulatory surgical centers, and a series of other, or a number of other outpatient settings. So we would love to have your participation in the project. And to start that off, what we ask is that you pledge your support to the project, and we ask that you visit healthinsight.org/getsmart. From this website, you can directly pledge your support by filling in some very basic information and signing or putting your signature into the website using your mouse, which is very cool. So I am the Oregon lead for this project, and I'd be happy to answer any of your questions, and I hope many of you will think about pledging your support today. Thank you for letting me go over that. Well, we're going to go into questions and comments in just a minute, but to let you know, immediately following this event, I will email you the evaluation. We have our next webinar is going to be taking a deeper dive into the care transition measures and best practices. And then to follow up with that, we'll do a roundtable call where hopefully all of you will be able to be on the call and we can hear about what's working well at your hospitals, and I will be reaching out to some of you to share your obstacles and your successes. If you know right now that you feel like you have some information to share that you'd like your peers to hear about, feel free to contact me. So at this time, we do have time for some questions. We have quite a bit of time. So we ask that you can either raise your hand, you can type your question or comment into the chat feature. And if you don't know how to do any of those, just unmute yourself and speak up. So I'll open it up I'll open it up for questions right now. Thank you.
You need to go into the chat to raise their hands, or?
They have it open, chance.
Oh, okay, sorry.
Can you see right away if anyone raises their hand?
Yeah, they go right to the.
Okay. Seems like all of you are maybe experts in this field. Maybe that's true. We do have a question come up. Ellen, do you want to take a look at that question in the chat? Would you mind doing that?
Okay, let me,
Looks like April has a question.
okay, let me get to chat.
She's asking,
Ellen.
she's having some issues with her EHR, trying to find a report on long bone fracture codes and ways to source that data. Do you have any recommendations for how to get to a good list in an EHR that might not be as heavily used, or I assume I'm kind of.
Ellen, did you find the chat feature?
I did, yes. Okay, so there are a couple of questions. So for April's question, typically what you need to do is it may not be in the EHR as much as it's going to be in the billing system or the coders, so that anybody who is coding your records is going to be looking for those codes. And so if they know and have those codes, then they can hopefully sort and see if it's usually a range, and the range is usually starting with any particular number. So I would go for the range of the fracture codes. But I know that for hospitals, yeah, without their ability to have the claims, but it's mainly from claim systems. So I would recommend going to whoever's doing your coding and your claims and see if they can match up the long bone fracture codes table, or have some way to identify those cases for you. And then the next question on the measures covered today, they are all required. So the ones that I covered were the MBQIP complete program. You can always report more measures, and MBQIP has optional measures as well, such as stroke and venous thromboembolism. Some critical access hospitals are monitoring those things and do want to voluntarily report on those, but the ones that are required are the ones that we covered today. And basically they're required by the Office of Rural Health Medicare Beneficiary Quality Improvement Program. Like I said, CMS has additional measures that the acute care hospitals are required to do as well. So both the MBQIP program and the state of Oregon, every program's flex program is obligated to the minimum required MBQIP measures. So that's what those were today on your presentation. The measures are per quarter. Yes, I should have said that up front. So all of the sampling, there are sampling guides for monthly if you happen to want to do reporting on, or monitoring on a monthly basis, but all of these are quarterly reports.
And she's also asking, I assume she's asking a question to clarify required by CMS in Oregon. I assume the MBQIP program is all one program.
It is national. It is, yeah, it is national for all of the flex programs in the country. So the expectation is that original 1,339 critical access hospitals, the hope is that all 1,339 are reporting on these minimum set of measures.
Nam, we're unmuting you right now. You want to go ahead, Nam?
And you may need to unmute your own phone or your audio on your computer. If you click, she might be on the phone. If she's on a phone line and using her computer, she might be.
Nam,
let us know what number you're on, Nam, and we might be able to unmute your telephone if you can chat what your phone number is. It might not be connected to your profile, assuming you're on a phone.
Is she on the interphone? Nam, can you tell us what phone number you're on? Oh, 2114.
Find it.
There it is. Okay. You're unmuted. Go ahead.
Oh, perfect. Okay, thanks, Carrie. So, Ellen, I had a question for you. I was under the impression that in order to submit the immunization data, we have to make sure that we are submitting the same information for the ED throughput measure. Is that correct, or we can just submit for immunization for inpatients?
You can just submit for, thank you for that question, because I failed to bring in that point. Yes, you can just submit for the IMM2 measure. You would go down to that question, you would answer that question. The problem with the ED throughput measures is that ED 1 and 2 and the immunization measures are kind of a merged measure in CMS. So that what the acute care hospitals have to do is that they have to report the IMM2 measure along with their ED patient measures. So whichever sample they use, they are reporting on the ED measures and the IMM on the same population. So for the MBQIP program, the ED measures are optional. That you don't have to report on the timing measures for inpatient emergency department. So that is why the worksheet has both the ED measures and the IMM measures, as does the CART software. So it gets a little confusing, but you're actually answering the IMM2 question once you put the demographics in. But the demographics cover all four of those measures. So,
right, because I was told last year that when I started my abstractions was that we were supposed to match the ED and IMM2, but if we don't have to for critical access, that's great, because then I don't have to do ED.
Yeah, and what it was an absolute necessity to pass for the hospitals to have the same number of ED and the same number of IMM in the rules making. So yes, but for MBQIP, no. You're just reporting on the IMM2 influenza, not even the pneumovax. If you want to report on pneumovax, you can as well, but that will not come through to the program either as a requirement.
Okay, and I needed a little more guidance on the helpful tips where you had mentioned that we need to enter the sampling and the population numbers in QualityNet. So does that mean that if I don't have an AMI or a chest pain patient and I do not put zeros for that, they're going to consider that I did not report on those measures?
Correct. What your reports from Telegen will say is NA, so not done, instead of NE, which is not eligible, so non-eligible. So what you want to do is use that population and sampling to make sure that they know and record you as that you had no eligible patients, or an NE on your reports, not an NA for not actually doing the reporting.
And we need to enter the sampling information by the 1st of every month, like the January number should be in by February 1st?
No, it'll be the first of a reporting quarter deadline. So February 1st was our last. The next one will be May 1st.
Right.
And then you'll be doing August 1st. And then you'll
Right.
be, yeah. So,
Okay.
and then November 1st. So it is quarterly on the 1st of the beginning of that quarter.
Okay, perfect. Thank you.
You're welcome.
Other questions? Other comments? Would anyone like to share anything that's gone really well for them in terms of these MBQIP measures?
This is Nam again, and I would just like to mention that the EDTC measures, we were not doing very well with them in 2015, and we have substantially improved last year. Like, we are at almost 100% on all the measures, and thanks to the EDTC measure being required by MBQIP, we were able to focus our attention on that. And with one of the collaborative events that were held last year, I believe through Office of Rural Health, the other critical access hospitals shared the tools they were using to standardize the collection of data for EDTC measure. And that has helped us the most in making sure that we are documenting everything we are sending. Because our problem was we sent everything, but if it was not documented, it was not done. So we have substantially improved our EDTC numbers, and again, I'm glad that that is one of the measures for MBQIP.
That's great, Nam. Thank you for sharing. I'm looking forward to the future webinars and roundtable calls where we can take deeper dives into these measures. I think that's going to be pretty exciting. So we'll be tapping into those stories more. Ellen, there's a question for you. I'll let you answer that.
Okay, let me.
Someone's asking if they can contact you directly later.
Most certainly, and let's see. Yes, and I don't remember if my telephone number is there. Let me.
Would you like to put in your how you'd like to be contacted in the chat?
Yes, I will type that in now.
My contact information is at the very end. Feel free to contact me and I can route you to Ellen, or Ellen's putting in her information. So I'm going to do a last call for anyone else that has questions or wants to share. All right. So one last piece of business. Katie, if you could advance the slide. And Namrata is going to talk about ORAC, or the Oregon Association for Healthcare Quality. So you have the floor, Nam.
Hi, thank you, Carrie. If you could go to the previous slide for a minute. So, can you guys hear me?
We can, but we're having problems going back.
Oh, that's okay. I can just say, I just want to take a few minutes to talk about Oregon Association for Healthcare Quality. And I think people who have been in the quality management field for past 2 or 3 years would know that there was an Oregon Association for Healthcare Quality Network. That was the association only for critical access hospital, but it dissolved in 2015. So this is another network where it is a great place to meet your peers, and this association is for the Northwest healthcare professionals, and so we have members from Oregon as well as Washington. And this is a nonprofit association which is focused on advancing healthcare quality through development and collaboration for Northwest healthcare professionals. And this organization, I'm on the board of this organization, and the reason I joined the board was to create an umbrella where other critical access hospitals can come together and we can share stories or our progresses with different processes, and a place for us to share ideas on how we are doing with different projects. And I just want all of you to know that the membership fee for the organization is $50. And the benefits of the membership is that we usually host 4 to 5 educational events every year. And if you are a member, there is a substantial discount that you would receive. And one of the courses that we offer every year is for CPHQ, that is a Certified Professional in Healthcare Quality. That is one of the most recognized certification in the healthcare quality field. And we offer a review course for that every year. And if you already have the certification, then attending these education events will provide you with CEUs, that is continuous education credits that you require to keep your certification. And you also would get discounts from other quality professional organizations like CPHQ Tutor. And if you go to the next slide, I just want to talk about the different events that are available this year. So as I had mentioned, April 7th and 8th in Vancouver, which is I think a 15-20 minute drive from Portland, we have a CPHQ review course. And at this time, the registration is open, and there's an early bird registration discount available. So if you could go to the ORH.org, that is the website, www.orh.org, then you will find the information about the course. I took that course last year, and I really enjoyed the course for somebody who was very new to the healthcare quality field. And if you do not have a CPHQ certification, then again, I would encourage you to attend the course and get the certification, because that will help you understand the different aspects of the healthcare quality field. And as the other courses are mentioned, we have some of these courses available, and please go to the website and look at the different things that we have to offer. And if critical access hospital members join this association, then I will be happy to work with the Office of Rural Health or with HealthInsight, and maybe we can come up with some programs that are geared towards critical access hospitals. And maybe we can even talk about doing some events in Medford or somewhere in Southern Oregon, so we don't have to travel so far. So if you have any questions about this organization, please feel free to contact me, and I will just type in my email in the chat right now. And thank you, Carrie. That's all I wanted to share about ORAC.
Okay, thank you, Nam. Does anyone have any questions for Nam about the association? I also took the CPHQ review course last year in Medford, and I thought it was great. I don't know if it's going to be the same presenter, but it was, I hope to get my CPHQ certification, and I felt like the review course was very well done and really tailored toward not just giving the information, but taking the test. So lots of good pointers, lots of time spent on how to prepare and how to be successful at the test, which I really appreciated.
Thank you, Carrie, and it is going to be the same presenter who will be coming down in April for the course.
Oh, that's great.
Mm-hmm. So feel free to contact me if anyone has any questions.
All right. Well, here is my contact information, and feel free to contact me at any time, however is most convenient for you. And that's all for today, and we'll be signing off now, and we hope all of you have a great rest of your day.